Today's lecture will cover standard precautions and an intro to microbiology. Our main topics that we're going to discuss today are principles of infection control, standard precautions, types of isolation, and some terms. So when we talk about nosocomial infection, that's a hospital-acquired infection, generally pneumonia or called hospital-acquired pneumonia. This is a pneumonia that occurs greater than 48 hours after hospitalization. Risk factors for this multi-drug resistant bacteria are if the patient's had an antimicrobial therapy within about 90 days of the infection. Their risk goes up if the current hospitalization is greater than 5 days. If they're in a community where there's a lot of antibiotic resistance or in a specific hospital, those patients with immunosuppressive disease or therapy and presence of healthcare associated pneumonia risk factors are also an issue. So with nosocomial infection, then they ask if they were sick before they checked into the hospital, and they'll ask then how many days do we say it's a nosocomial infection. Well, again, that definition, by definition, it's greater than 48 hours after hospitalization. So if somebody develops a fever and high white blood cell count within 24 hours, that would not be nosocomial infection. So let's think about a patient that has had abdominal surgery, and what do they want the respiratory therapist to do? Well, they want the respiratory therapist to come in and have them take some deep breaths with the incentive spirometer. And the patient says, well, no, I don't want to deep breathe. And then so what happens when the body doesn't drain those fluids because they're not deep breathing? Those fluids sit there and they can become infected. And again, IS would have helped move those mobilized secretions. So in addition then, this patient has develops a urinary tract infection. They're in the hospital, the temp goes up to 101, they have a catheter, and then do they say, well, is it a pulmonary problem or is it a urinary problem, this patient that had this abdominal surgery? Well, they can look at the type of organism that develops. If it's a urinary, it's going to be if it was caused from the urinary tract infection, they're going to look and see, well, is there E. coli present? If there was E. coli present, this would be an organism that colonizes in the bowel, and so we could point out where this infection started. So this is why it becomes important to look for the culture of the culture information when we're looking at patients with infections, especially if they're a nosocomial infection, because it's really hard to say where the infection came from. Was it a incision problem with the surgery? Did the surgery cause the infection? Did the pulmonary cause the infection? Where did it come from? When we think about chain of infection, this is kind of a classic picture that's shown here. We have to have a source. We have to have something that has a potential to cause disease. So pathogenetic is that potential to cause disease. We can have many organisms on our body, in our body. That doesn't mean we're sick. So then we need some sort of reservoir, some place for it to live. We know these pathogens like warm, moist environments. There has to be a means of escaping from this reservoir. Then there's some sort of transmission and entry, and we look at how susceptible the host is. We know that we can get sick, but we're not always sick. We're exposed to pathogens all the time. Pathogen, by definition, is not the same as a bacteria. These pathogens can be viral or fungal, and we'll go on to talk about those differences later. So if we look at maybe respiratory syncytial virus in children or bronchitis in adults, how do we get that? Well, where is it? People carry this in their nose, in their secretions, and we get it from our classmates or housemates. So let's say a boyfriend and girlfriend are at the movies. She's a carrier. She has this reservoir. She has respiratory secretions. They go to the movie. They sat really close. She sneezes, or she coughs, or they kiss. Mwah, mwah, mwah. Then we have this means of transmission. Do they get sick? Well, if they have a strong immune system, maybe not. But if it's a typical teenager, they might be staying up late, not eating all that well. Their immune system may be compromised, and then he'll get sick. On to some of these modes of transition. Well, there are several ways. We can have direct contact with a pathogen. That's like the last example that I gave you, from touching or kissing or mouth to hand movement. It can be a more indirect contact from a fomite, which is an inanimate object. This is how head lice are transferred from one person to another. How did that disease-producing microorganism travel? It can travel through a hat or a comb or a coat. Once those little head lice get in classrooms, they travel pretty easily. It can also be an airborne transmission, meaning something that's small enough to float around. This is the prime example of this is tuberculosis, is an airborne issue. Vectors are invertebrate animals that can transmit microorganisms. These are the easiest one to remember here as a vector is a mosquito that would carry West Nile virus that we still struggle with a little bit, but it has been worse several years ago. The vehicle, it can be a material that serves as a means of transmission. So this is like a carrier. We would say maybe a doorknob or something laying in the patient's room that we touch and then transfer to another person, such as a stethoscope. And so think of some examples of each of these some additional ones besides the ones I gave you to get a clear understanding of this. Oh. So what about isolation guidelines? There's two tiers. We talked about this some in patient care skills. There are standard precautions. Standard precautions, again, those things that we do with every single patient that include washing our hands, checking the patient's ID badge, and noticing anything else that's posted. So then transmission-based, these are the ones that will be specific to individual patients based on what's going on here. So we have three of these that we'll talk about a little bit more: contact, airborne, and droplet. So with standard precautions, every patient, we follow these. And I encourage those of you starting out in practice to err on being careful. So you go in for oxygen therapy and ask yourself, do I need gloves in this situation? Well, you're putting a cannula in the patient's nose. The patient could cough. You want to have gloves on. Obviously, we know we're going to wear gloves if there's any blood or body fluid. Sweat, however, is not considered a body fluid that transmits body fluids. So sweat is kind of one of those things that's nice to know the difference there. But if we're going to roll the patient, we don't always know what's in the bed. You should probably put gloves on. Definitely when we suction, we're going to wear gloves. If there's ever any non-intact skin, you want to wear gloves. If you can't see it, err on that safe side. Gowns and face masks should definitely be worn whenever there's a risk of splashing liquids or creating aerosols. So this is one thing that we don't talk a lot about in patient care skills, but is important for us to know as respiratory therapists, that we will increase the standard precautions to use gown and face protection when there is a risk of transmission through whatever we're doing. And this is important to us because we suction patients where there's a potential to splash fluids on us, and we obviously are creating aerosolized particles very, very often. Goggles are also important to use. It really depends on where you're working and the type of patients that you're exposed to, but you want to know where those are in the hospital, or carry a pair of your own. So contact precautions. This is patients potentially in isolation for a MRSA, MRSA, methicillin-resistant Staph aureus infection. Methicillin is a common antibiotic, and the patients become resistant to that antibiotic. So these are for precautions where in patients with MRSA, we would not want to spread the organism from direct contact. So contact precautions is just how it says there, touching the patient or touching other surfaces in the room that have been in contact with the patient. Rotavirus is another example here. This causes explosive diarrhea. When you're working with patients that are in contact precautions, really look at the type and identify the infection and know what's going on with that particular patient, so you know what to be especially careful for. So these are instances where when you're doing breath sounds, it would be wise to wear a gown and definitely gloves, but you don't always have to wear a mask. Again, that's going to depend on the procedure that you're taking care of. But again, a gown, because that risk of putting your scrubs that you're wearing the whole day in contact with that potentially transmittable microorganism. Airborne precautions are those particles that are droplet nuclei, contaminated size or dust particles. They are that size of around 5 microns. They can remain less than 5 microns. They can be suspended for a long time, even after somebody's left the room. So these are tuberculosis or measles or chickenpox. This is the instant where the HEPA mask, the high efficiency particulate air masks, are worn. Those are specially fitted per user, and it's definitely not a one-size-fits-all mask. It's also sometimes referred to as an N95 mask. Basically, these are fitted where you put the mask on and a fit test is performed where they're either kind of blowing some smoke or some aerosolized sugar around it. So if you can smell it while they're doing this, then the mask doesn't fit. If you can't smell it, then the mask does fit. And this seal on these HEPA masks or the N95 mask is very important. You have to seal this every time you put it on. And sometimes these masks are reused and they're put in some sort of mass storage system, and it's important that those are stored in a way that the mask is not misshapen in storage, so when you put it on back again it fits. And you also it's best to put these in paper bags where they can actually be let to dry, and label those from front to back so you're not contaminating your mask. But individual hospitals are going to have policies for this. Most of the time as students, you don't go into patients' rooms with airborne precautions, so we talk about it a little more, and and you'll really get an idea of this once you're employed in a hospital, because the fit testing takes a little bit of extra time, and they want to make sure trained people are using these masks, and as students sometimes they don't have the opportunity to always provide that training when you're there. But that's how those work, so you may see those in the hospital and take a look at how the therapists are using these HEPA masks in the various sites you're visiting. Droplet precautions are those particles greater than 5 microns. That's the big difference between the airborne and droplet precautions, or that droplets are a little bit heavier. They're not going to be suspended as long. They usually don't travel beyond, we sort of say 3-foot range of location. So if you put your arm out, it's about 3 feet, and so you kind of say, well, that's kind of the space where droplets are going to take effect. Most of the time as respiratory therapists, we're closer than 3 feet, so we would follow the droplet precautions. You will see nurses walk into the patient's room, with droplet precautions without the necessary protection, and their defense is, well, I'm not coming within that kind of 3-foot space of the patient. And if you think about this, somebody sneezes, those particles fall down, gravity falls them out. The flu is off. Patients in for the flu are often in droplet precautions. But these are patients where it's meningococcal meningitis, influenza, like I mentioned, mumps or rubella that you've all been vaccinated for, but influenza is probably the one, and occasional meningitis that you will see patients in droplet precautions for. So these talks are not meant to scare you. Not all bacteria cause disease. The mass majority of bacteria are positive things. They're all over our body, and they do more harm than good. But there are a few bacteria that cause disease, so we label those as potentially pathogenic. So many good bacteria are in, especially if you think about our gut. And so we have good bacteria in our gut that help produce vitamin K that we need for clotting. Well, what happens if we take an antibiotic? Antibiotics don't know the difference between the bad bacteria and the good bacteria, so all bacteria are, not all, but the majority of bacteria are killed. And so you've probably heard the thing where if you're taking an antibiotic, you should eat some yogurt, because yogurt has some probiotic properties where they will help restore that helpful bacteria. If you want to go one step further, something that has many more probiotics is something called kefir. So here's my little slide of the friendly bacteria that are in there doing a good job helping us digest our food and getting the nutrients out of those things that we eat. And then there's a few unfriendly bacteria in there that can cause some problems. So normal flora. Our bodies are composed of more bacteria cells than human cells. So the normal flora, the organisms on our skin all the time, are something like Streptococcus. Where is it on us? It's on our skin. And some of us even carry strep. So we have all these normal things that are competing for our kind of food to live off of. And so if you think of something that, how do these normal flora help? Well, on our skin, if we come in contact with MRSA, the helpful bacteria compete for that food and that moisture and that temperature. And if the good bacteria are there to take up the food, it's not a good environment for the harmful bacteria to live. But if you think of somebody where it's more potential to harm, somebody that's obese with a really big belly, to give you this visual, with overlapping skin folds, where there's maybe yeast growing and bacteria where it's too moist in that skin, well, that's going to be a better place to harbor some of these other bacteria. So we can do the opposite, though, by keeping our skin too clean. If we're using antimicrobial stuff all the time, the skin becomes more dry. You might have noticed this after a day at the hospital. You can get cracked or bleeding skin, and you have a risk of having open sore. And that will increase your likelihood of having a harmful bacteria attack. That's one reason why we encourage you to wash with warm water as a mechanism of washing your hands, and not dry and not super hot water, because the hotter the water will dry out your skin more. So at home, I don't have any antibacterial soap. I shouldn't say I don't have any. I don't have it stocked in my in my bathrooms all the time. I have one bottle of antibacterial soap that I'll occasionally use after I've worked with raw chicken. There's just something about that I've decided that I might want some antimicrobial soap. But for the most part, I'm going to say I want some amount of that bacteria in my kids' living environment to have some of those helpful bacteria. I don't want to be killing them all the time, because I want my kids to build up a healthy immune system. So where are these sites? Here are some of the normal flora. So I mentioned this. The skin has that Staphylococcus aureus that you've heard of. The oral cavity and the nasal cavity have streptococcal pneumonia. The intestinal flora have bacteroides, and the urogenitalia flora have candida. So lots of places with different organisms. So when we talk about, it's important to have a understanding of this concept of a privileged area. Privileged, I kind of think of this as a VIP, like a very important area where, you know, we only want certain things or people going there. So when we think of this, if we're going to say something sterile, this is how we want blood, or if we're getting a blood culture. If we grow anything, that would be abnormal. The lungs, on the other hand, they're kind of intermittently, you know, the upper part of our airway is not totally sterile. The lower part, you know, we kind of think below the vocal cords, we try to keep as sterile as we can. The pee and the fluid from the bladder is sterile. Obviously, cerebral spinal fluid is sterile. Joints, the synovial fluid in the joints is sterile, and the pleural space is also sterile. But we have other areas in our GI tract, primarily, that are not sterile. So what's a pathogen? A pathogen is a disease-producing microorganism capable of causing disease. So it's a microorganism capable of causing disease. Where do they come from? Well, everywhere. Our cell phones, our keyboards, the faucet. You know, my kids love Subway. I go there and I watch them put on gloves before they wash their hands, and so I remind them of the difference there. They love me at Subway. When we talk about doing our head-to-toe assessment, we don't go from feet to the head, we go from head to toe, because we change our gloves when we go, because we want to work from clean to dirty. Your clinical instructors have probably mentioned never wearing gloves outside the patient's room. Why is that? You know, that's because we don't want to carry whatever was in that patient's room to the next patient's room. We want to take those gloves off in the patient's room. So how do we get disease then? Well, to get disease, the organism must be transmitted from host to host. It must be able to gain entry, and the organism must be able to evade the body defenses and multiply in the host tissue. Obtain some nutrients and produce symptoms, then potentially exit the host. So any deviation or interruption from the normal structure and function of any part of the body can lead to the spread or cause of disease. So what do the pathogens have to do? I mentioned some of these. They must have babies and spread. If we think of a computer virus, whoever invented the computer virus did not want just one person to get the computer virus. They wanted to invent something that would go from one person to the other, and many computers would crash because of it. Pathogens are the same way. They want to reproduce and replicate themselves and transmit to others. So how does pathogenesis occur? Well, several ways. It can be direct person-to-person spread. So that's kind of considered a horizontal transmission, or it can be more of a vertical transition where it relies on the persistence of the agent to transfer infection from parents to offspring. So in this case, you could think of when infants are born, they can have something spread from their mother to the baby. So AIDS can be transmitted that way. Or it can be something where a mosquito bites you and pokes you, and that's how the disease is spread. So there's a couple terms here that you want to think about. Invasiveness is how the actual ability to invade or break into the host. So mosquitoes can be fairly invasive if there's a lot of them and they're hungry. How toxic they are is that their ability to produce toxins. Virulence is the combination of those two, the toxicity and the invasiveness that overcomes the host defenses. Oops. Okay, last slide here is looking at these different sites of entry. So important to remember all of these. I think we've covered this enough, but the main areas that we can gain entry into are the eyes. So where either we touch something and then we rub our eyes and our eyes are moist, and that is a body fluid that we would be possibly contaminating. Obviously the mouth. This is why kids are sick all the time. They're putting random things in their mouth that they've touched from places that they probably wouldn't have if they would have known better. Respiratory tract, our GI tract, skin, obviously we look for abrasion or other arthropod vectors that come into play there. The urinary tract and reproductive tract and the anus are the main sites of entry for illness.